It is a responsibility of the government to provide effective and sustainable health care to its population. And for the government to do that, then it is important that a government has a reliable financing system. And that is why linking health financing to government fiscal responsibilities or government domestic revenue generation is important, because that provides the government with the space to be able to take into consideration health expenditure. So that makes domestic health financing important to any government, because the government, if the government was to rely on, for example, out of pocket, the user fees, this is not sustainable, because this affects households, and the spillover effects is that the poverty levels at the household levels also also go up. And as we've observed in the recent past, the level of the donor financing to health has also come down. So the only way to sustainably finance health is to look into the domestic resources and how we can create more space for health financing. Africa experience a number of challenges in terms of financing domestic health. One is that they have not fully prioritized health expenditure. So then that means that the health sector is coming more after other sectors. Actually, in certain countries, for example, Kenya, you find that probably health sector in terms of budgeting, the budget resources, it is left to lag almost the sixth in terms of those 10 or so sectors. So one issue is that of prioritization. Another thing is that when you talk of resource allocation, then you are moving into the space of political economy. So if you are seeing a sector is not getting enough resources, what comes into mind, therefore, is the political responsibility or the politician appreciating the value of health, and especially so when it comes to primary health care, which even unlike the overall health, you're finding that allocation to primary health care, if you consider to others, for example, the curative health and the rest, there's a lot of resources allocated to curative health within the health spending, but not this. Because they don't, for example, see the value at the first instance. You don't see the value. You're saying you're going to invest in preventive health, and as opposed to, say, for example, palliative care. So these make health indeed lag behind, and that it lags behind essentially when you also talk about the issue of primary health care, which is very important, the girl-child health care, and even the women health care. Which are very important, and they therefore lag behind. So that is another issue that makes another challenge, that political responsibility, that political involvement and political appreciation of health. Another thing which also is a challenge is the issue of domestic health financing data that can be used to inform healthcare financing, because at the end of the day, when you're doing a resource allocation, then you go to have a justification of why you feel that your sector needs to get more resources. But you're finding that the quality of health financing data is not as good. So this then therefore mean that those responsible for resource allocation may not be able to, for example, make justification for more money. And another issue probably is also the dialogue between the ministries responsible for financing and planning and the Ministry of Health. Probably this dialogue is not as the dialogue between these two ministries or three ministries is not that strong, because on the one side, the Ministry of Finance and Planning, which is responsible for resource mobilization and resource allocation, or which give guidance on this resource management, does not understand health resource utilization. So probably that's lack of dialogue, so that the right hand knows what the left hand is asking for, maybe another challenge. And again, in the health space, a challenge in Africa has been the way stakeholders work. There's quite a bit of resources in any space, in development space, whether it is health, education, or otherwise. But then you find in most cases, all the stakeholders are working in silos, kind of. They work, this one is working, probably pursuing this course, this one is pursuing the other course. Then at the end of the day, they don't seem to be implementing the national strategy of health financing, because each one of them is working independently. Indeed, what is important is to do all it takes to stop people from going to the hospital. It is cheaper to invest in prevention than in curative health. If you look at the statistics, and perhaps that is why more money goes to the curative, our health-seeking behaviors from a very long time is one where you seek health when whatever you are suffering from is fairly advanced. That is when you feel that, oh, so this thing is becoming a little bit serious, and then you go and seek health. So that comes with a fairly huge amount of resources if you look at that. So per capita cost in terms of primary health care would be better, and you will be able to reach more people, ensuring that the population is healthy. It is more simpler. It could be done at the lowest level of healthcare management. So if you really want to achieve universal healthcare, then the best place to focus on is primary healthcare, so that you invest to ensure that your population is healthy and they don't seek advanced health treatments, which are very costly. So that is why I think for us to get into the theme of addressing the universal health coverage, then we need to focus where the disease prevalence is not high, where you will basically tell people that for you to avoid waterborne diseases, you may want to treat your water. For you to avoid other diseases, for example, like malaria, you may want to sleep under a treated net, or wash your hands so that you don't go to the hospital with an advanced case of diarrhea or something like that. So that is the feeling that investment at that level would be much better, cost-effective, easy to implement than would be the case of a curative, where you now have to invest in doctors, more doctors, not more community health workers who are affordable. You have to invest in intensive care units, not just a dispensary. So I think that is the gist of it, that we have to focus where our money, there is greater possibility of having value for money. The national governments across Africa, and in most cases in the rest of the world, have done quite significant progress in terms of developing health financing policies or strategies. Indeed, if you were to go to the Ministry of Health, they have almost each and every strategy for each and every possibilities. They are the strategies, and they are plausible strategies. Those that, if implemented, could at least address some of these needs. So, one, it is just that we all need to not invest really, but to implement the existing strategies. That is number one. Yes. The other thing, and which I've mentioned earlier on, is the issue to be able to justify why we need more resources for health. So we must be able to demonstrate effective use of the resources that we have. One question from a budgeting perspective would be that you are asking for more money for health, but your absorption of what we already gave you is far below what we would call optimal absorption. I mean, if you say you are going to implement activities, and based on program-based budgeting, you know you are going to absorb 100%, and you find that there are certain countries or divorce systems whose absorption is almost 10%, less than 10%. So if your absorption is 10% and you are asking for more resources, I think it is important that we prioritize absorbing or effectively using what we have before we could be able to put a case for additional resources. So that's why we need to demonstrate the effective use of the resources that we have. So we have to advocate the African countries and even the subnational governance systems need to advocate for adequate resources, but then the arguments should now move from curative to making health appear in the productive sector space. Because you're saying, if you invest probably in primary healthcare, you will be seen to be trying to encourage your population to remain healthy and become productive. So let's also advocate for resources going towards that, and we should prioritize that. Another thing that we may need to do, and this is in the short term, because of the agency of resource requirement in health, we may want to look at sector-wide kind of approach, where as we do our budgeting, then we may want to reprioritize the health requirements in the budget, so that the budget making process, it's a process. So if there is no fiscal room at the moment for the tax, the tax-based revenue to increase, then why don't we say the valuable resources within that could be redirected towards agent health financing needs. So that is also another way of looking at how to, in the short term, that is a short-term intervention. Because if the resource base is not expanding, there comes a time of saturation where even that which is there may not be now for everyone. So in the short term, there may be a reprioritization of fundings to just address agent health needs. But again, what is important, and which I've mentioned, is to expand the tax bracket or the tax base. And when you are expanding the tax base, effectively what you are saying, as it expands, the tax revenues are increasing, then we should be able to see the health allocation as a percentage of domestic health expenditure going up. And that is possible if, for example, we have been able to justify that we are effectively using the resources that is there. Then as the tax revenues increase, then you're able to have more. The last one, and of course this goes back to the issue of data on health financing, the comprehensiveness, the quality. Yeah, and the ability of the people who handle health financing should have capacity, technical capacity, to be able to effectively analyze data and present this data to the table of resource redistribution, so that they are able to be seen, they are able to show the evidence that indeed there is need and there is value for investing in healthcare. So that issue of data is also important as part of those priorities that we should look at. As a health economist, and what excites me in this work is that first, we are coming to the table where the politicians are sitting, and as I mentioned before, in a political economy, having an engagement with the politicians who are largely responsible in terms of formulation of legislations that effectively would be able to increase the resources addressed towards health. We are coming to that space that they are in. We are going to engage with them. It is good that we have a background, we have an understanding of what probably needs to be done. And in the next few weeks, we are, for example, in Kenya, going to have a very good meeting with the Council of Governors on matters of health financing. I think such opportunities, when you have them, you are able now to communicate what probably you would have not done had you not had that space. We have the opportunity to do this. We have the time to do this with the politician. And if you look at the rallying call for the Sustainable Development Goals, the Sustainable Development Goals say that leave no one behind. And because of this opportunity that we are having and the ability to contribute to the space, I think that is why I would feel that I would want to work towards a health for all.